Well, I apologize in advance if anyone's disturbed by my title, but those who know me know I like to keep things light because a lot of times we deal with things that aren't so happy and so friendly to patients who come with problems. But in addition, I think I have an excuse for this title because if you see one of my employers here, it's the Geisel School of Medicine at Dartmouth, which is actually Dr. Seuss. So it might be attributed to him, his influence anyway. What I thought we'd do today is go through just a very brief review of normal early pregnancy and then focus mostly on molar pregnancy, a little bit about yolk sac abnormalities and amnion abnormalities, and finally end with a chorionic bump, and talk somewhat about the genetics and epidemiology and clinical characteristics of molar pregnancy because it's quite fascinating. I think even overshadows the ultrasound findings a lot of times. Well, as we can see here, this is a normal early IUP at around 4 weeks. We have a round, smooth gestational sac with a thick decidual reaction around it. But again, as Dr. Duboulay nicely showed us, you can't really tell about the viability in this situation, but so far so good. We can see the double sac sign in some cases here. Again, I think that's fallen out of favor to a large degree, but if you see it, it's also somewhat of a favorable sign here. You can see this is made up of the decidual basalis, the decidual capsularis, and decidual parietalis, which I can never keep straight. But generally, I tell my residents, you see a gestational sac at 4 to 4.5 weeks gestational age, usually 2 to 3 millimeters in diameter is the first finding that one can see. You'd like to see a hyperechoic thick decidual reaction. The rim should be at least 2 millimeters thick or more so. Eccentric implantation is a good thing usually, and you can see the decidual sac sign or double sac sign. And look for that round or ovoid shape. It shouldn't be crenulated or flattened. Not a good thing. And the theory is that the decidual capsularis and decidual parietalis make two lines in the endometrial side of implantation. And you can see them here. These are not the decidual basalis and the chorion frondosum, which form the placenta, but these are the decidual capsularis here, which surrounds the early gestational sac, and this decidual parietalis, which outlines the uterus. So these form the double sac sign here. So getting into gestational trophoblastic disease, we'll talk mostly about the first two entities, hydatidiform mole complete and partial hydatidiform mole. Talk a little bit about invasive mole and choriocarcinoma. I won't really mention much about placental site trophoblastic tumor because there's not a whole lot in the ultrasound literature at least. Gestational trophoblastic disease as a whole is quite rare in the Western world remotely, Australia and New Zealand, about 1 per 1,000 pregnancies. It's much more common in Southeast Asia and Japan, anywhere from 2 to 3 per 1,000 pregnancies. And there's certainly an increased incidence, which has been shown in numerous studies among Native Americans, Inuits, Afro-Americans, Hispanics, and Asians. And there's a decreasing prevalence overall, I think, attributed largely to improved diet and improved socioeconomic status in most parts of the world. Hydatidiform mole in general, again, should be considered to consist of 3 entities. One is trophoblastic proliferation. The trophoblasts are the cells derived from the embryo that invade the decidua, forming the early placenta. Villus edema is the second one, and the third one is an absent or abnormal embryo or fetus. Now, talking about the complete mole has relatively normal chromosomes. Most are 46XX, 90% or so. And what's postulated is that a sperm fertilizes an egg with either inactive or absent chromosomes, and you get, therefore, a duplicate haploid chromosomes from the male or the paternal side. You have an absent fetus or embryo in the complete mole, and there's a significant risk for developing post-gestational trophoblastic disease neoplasia, i.e. invasive mole or choriocarcinoma. And here's a schematic diagram showing the sperm here with a 23X, a haploid chromosome, fertilizing an empty or inactive chromosomal oocyte, and then forming with duplication a 46XX chromosomes in this complete mole here. Less commonly, we have 2 sperm invading or fertilizing an oocyte without chromosomes and yielding a 23X, 23Y, 46XY complete mole. Again, paternal chromosomes only, diploid, but paternal chromosomes. Now, a partial mole is a little bit different. You oftentimes have fetal tissue or embryonic tissue. You may just have a gestational sac without any tissue there. You have villus edema, certainly, but the trophoblast is not entirely replaced. It's only focally hyperplastic. And the chromosomes usually are 69XXY, usually I say, and we'll get into that in just a few minutes. And there are 2 sperm which are fertilizing a normal ovum, yielding 3 sets of chromosomes, or triploidy. This has a much lower risk for developing choriocarcinoma or invasive molar disease, less than 5%, probably down to less than 1% in some series. And it should be noted that 85% of cases of triploidy are partial moles. And here's the schematic. There are 2 sperm that are haploid or 1 diploid sperm, which are less frequent, fertilizing a normal ovum and yielding the 69XXY or 69XXX chromosomes here. So this partial mole consists of both maternal and paternal chromosomes, or triploidy. What are some of the risk factors for complete mole? Advanced maternal age is certainly a risk factor. Twofold for those women who are over 35 years of age, 7.5 times higher in women who are over 40 years of age. Very young women are also at increased risk, twofold for women less than 21 years. And history of a prior spontaneous abortion have a 2 to 3-fold increased risk as well. And interestingly, a study showed that there's an inverse relationship to beta-carotene intake and animal fat dietary intake. So if you like to eat lots of carrots and bacon, you're probably okay. Some of the risk factors for choriocarcinoma, this is the metastatic disease. Prior complete mole is a big risk factor, 1,000-fold increase compared to normal pregnancies, a prior mole. Ethnicity, again, the ones that I went over before. Advanced maternal age, again, long-term contraceptive use, and for unknown reasons, blood group A. Invasive mole is sort of in between a benign mole and a choriocarcinoma. It's a benign tumor that aggressively invades locally through the tissue or veins. 10 to 20% of moles will result in invasive moles. Usually, again, it's the complete mole. About 15% of these will metastasize to lungs or vagina. That's when they earn the moniker choriocarcinoma. Most often they're diagnosed clinically rather than pathologically, usually after HCG elevation after molar evacuation from surgery. And usually they're treated with chemotherapy and results are generally pretty good. A little bit about the epidemiology of choriocarcinoma. Very rare, 1 in 40,000 pregnancies in the Western world. 1 out of 40 hydatidiform moles turns into a choriocarcinoma. And in Southeast Asia, it's much higher, 9 per 40,000 pregnancies. Japan, a little bit lower, but still high, 3 per 40,000 pregnancies. And the incidence of both moles and choriocarcinoma have declined over the last 30 years, again, for those reasons I mentioned previously. Choriocarcinoma clinically, it directly invades the myometrium, then metastasizes, usually through the veins or through the lymphatics. The lungs are the most common metastatic location, followed by brain, liver, and so on. 25% will follow an abortion or tubal pregnancy, about a quarter a normal gestation, and then about half arise from moles. But only, remember, 2 to 3% of moles, small number, progress to choriocarcinoma. Complete mole clinically, vaginal bleeding, again, this is what the topic is for today. 6 to 16 weeks gestation by dates, size greater than dates in only 30% of cases, which surprised me. Hyperemesis in 10% of cases. Pregnancy-induced hypertension, 1%. And the thecal lutein cyst, which I remember learning as a resident, was about 50%, is now down to about 15% of cases. And HCG is usually over 100,000. The partial mole clinically, even less overwhelming. Greater than 90% present as an incomplete or missed abortion. And 40 to 60% of cases are detected by routine ultrasound, usually diagnosed after DNC is obtained, yielding decidual or placental histology. Vaginal bleeding is a presenting system in about 3/4 of cases. HCG levels, again, these are lower in partial moles, less than 100,000 in 90% of patients. And size greater than dates, hyperemesis, pregnancy-induced hypertension, or thecal lutein cysts are very uncommon. And at least 10% of moles diagnosed by ultrasound are considered false positive. And these are so-called hydropic abortion or hydropic degeneration of the placenta. Another tidbit about clinical gestational trophoblastic neoplasia. Again, this is the invasive mole or choriocarcinoma, the mole that's gone on to complications. This usually presents as irregular bleeding after the evacuation of benign mole. Other signs would include an enlarged, irregular globular uterus and bilateral ovarian enlargement. And the differential is, again, RPOC that Rusty nicely outlined for us, endometritis, or a primary or secondary malignancy. So here's some images finally. Partial mole, this is a woman who was about 12 weeks by her dates. You can see sort of the thick cystic placenta here with a somewhat irregular or oblong shaped gestational sac, really thick placenta. So we suggested a possible partial mole, and they did a DNC, and we were correct in this case, although we certainly aren't all the time. A lot of the interest in partial moles is trying to distinguish them from hydropic degeneration or just benign missed abortions. Here's a clip, hopefully this will run, showing you the partial mole with these flat, kind of irregular, oblong sac, and the very cystic-y, thick placenta here. This is a close-up here, showing the little embryo without a heartbeat here and the cysts that have formed in that abnormal placenta. Another case of a partial mole. This one had a huge HCG of 1.5 million. Note the very thick placenta here with several small cysts, so not so much cysts, but thickened placenta in an abnormal fetus. This was a partial mole. On pathology, one can see that the placenta is derived of lots of small grape-like clusters here. Here's the gestational sac with some embryonic tissue within it, and on histology you can see the dilated edematous villi, as well as some focal trophoblastic hyperplasia. Sorry about that. This is probably one of my take-home slides here. Dr. Fine in 1989 did a study from the Brigham, including Dr. Dubélé. They looked at 2 criteria for diagnosing a partial mole and trying to distinguish it from a missed abortion. And they found 2 criteria were helpful. One is the transverse to AP diameter of the gestational sac. If that's greater than 1.5 ratio, consider a partial mole. And so transverse diameter means horizontally oriented, no matter whether it's a sagittal or transverse image. And the AP diameter is the vertically oriented diameter here. So you want kind of a flat, irregular, or oblong sac. If it's like that, high chances of it being a mole. And the other criteria they looked at was cystic change, irregularity, or increased echogenicity of the decidua, of the placenta or the myometrium. If those 2 were present, there was an 87% accuracy rate for partial mole diagnosis. If both of these were absent, it's a 90% accuracy rate for missed abortion, and 50% of the cases were either both positive or negative, so a pretty good predictive value for seeing these entities. And again, here's the partial mole. Again, you note the oblong sac. It is wider than it certainly is high. This is a case that we called a possible partial mole because, again, you see the sac is longer or wider than it is high, and there was some cystic change in the placenta, but it turned out just to be hydropic degeneration. Complete mole, on the other hand, I think is less of a diagnostic conundrum. Typically, it's a very thick, somewhat heterogeneous cystic placenta here, as in this case. We don't see an embryo or even a gestational sac in most cases. I've not found vascularity to be that helpful. There's another case, more recent case, came through, again, placenta very cystic-y, some areas of larger cysts and hemorrhage here. And again, you put color on. I didn't get much blood flow out of it. Sorry. What you see on gross pathology are this very classic cluster of grapes here, very edematous villi here. This is from a 41-year-old who had an HCG of about 500,000. And another patient, a very kind of cystic-looking clusters of grapes all over the place, very abnormal looking placenta here. Choriocarcinoma clinically secretes HCG, as you're probably aware. It comprises both syncytial and cytotrophoblastic tissue as well. We talked about metastasis to the lungs, brain, and liver. You should know about the non-gestational trophoblastic origin. You don't see it very often, but certainly those of us who do GU imaging, like testis imaging, have run into the mixed germ cell tumor containing some choriocarcinoma elements as well. This is felt to be from a gonadal origin and no antecedent gestation. And on choreo and histology, you can see the very bizarre pycnotic nuclei with a lot of mitotic figures as well. Lots of hemorrhage here on this lower power field as well. So that's what choreo looks like on histology. I just thought I'd mention placental cystic lesions because these sometimes are a problem, usually on outside ultrasounds that get referred to us. These usually are benign. Usually they represent intervillous thrombosis or decidual septal cysts. Can even be so-called venous lakes, although I'm not sure what the origin of venous lakes derives from. or fibrinoid degeneration. They're common in the second and third trimesters, usually as we go in advancing ages in gestation. They're more commonly seen. They're often seen in the subchorionic space or the edge of the placenta. But if there's more than 5 of them that are sizable, or 3 or more or greater than 3 centimeters, they can lead to placental insufficiency. So if you see a lot of them, you might take note of that. Here's an example of a pretty ugly looking placenta we saw. Lots of cystic hypoechoic areas here in the placenta. Color flow usually doesn't show much blood flow to these areas at all. But at pathology, we were quite surprised to see a normal term placenta. Nothing was made of the placenta at all. So don't mistake these as being molar disease. I'd just like to touch briefly on a coexistent mole and fetus, which I've seen one case of. And this was a woman who came to our emergency room about 3 months after delivering a healthy baby. She was having some hemoptysis, and they did a chest x-ray, and she had pulmonary metastases that turned out to have come from a choriocarcinoma. And so I did a little detective work and got the outside ultrasound from an outside physician's office. Again, this is about a 15-year-old case, so the images aren't very good here. But this is what the choriocarcinoma looked like, and it wasn't recognized. It was called an intrauterine fibroid with this sort of cystic-y appearance here. And fibroids don't generally pooch into the gestational sac, at least not in my experience. So if you see this in addition to a fetus here, consider a coexistent mole and a fetus. And here's a case loaned to me by Dr. Hall from the University of New Mexico. Fetus here, fetus was totally normal here. Here's this thick cystic placenta here. This is a coexistent mole and a fetus, so lots of obstetrical issues about how to deal with this pregnancy. Finally, talk about placental site trophoblastic tumor. Didn't really find a lot in the ultrasound literature about these. It's a rare tumor. It secretes human placental lactogen rather than HCG, so a little bit different biochemically. Most occur after normal pregnancy. Generally a good prognosis if discovered recently after pregnancy, but 10 to 15% die of disseminated metastatic disease. And finally, just want to end with this actual quotation from a Dartmouth Hitchcock pathology report. This report said, first trimester complete hydatiditiform moles may overlap histologically with partial molar pregnancies and even hydropic abortuses, since the classical features which are more evident in the second trimester are not typically as well established in the first trimester. So if you're having trouble distinguishing, partial moles from missed ABs, we're in good stands with the pathologist, certainly. Just a little bit about the yolk sac here. Normal ultrasound visibility between 5 and 12 weeks. The maximum size is around 6 weeks, 6 to 7 millimeters, and peaks around 8 to 9 weeks, usually regresses by 10 to 12 weeks. And it's really relegated to secondary status once the placenta takes over, but it's very important in supporting the early embryo. And any kind of abnormal shape or echogenicity or calcification is usually a poor prognostic sign. But this is one example where I say don't take 100% in these findings. This is a somewhat irregular crenulated shape to the yolk sac, but it was a normal embryo at this stage and turned out to be a normal healthy fetus. So just the abnormal shape I'm a little bit reluctant to say is a really good sign, but certainly too big is a bad prognostic sign. Here's a case of early pregnancy. We see the double sac sign here. But this is the yolk sac, and it's measuring 7 millimeters. Again, for those who are measuring these, you always want to measure from the inner border to the inner border to get the measurement. 7 millimeters, non-viable outcome. When you see this, the game is over pretty much. This is a calcified yolk sac. It's not shadowing, but I've seen some that have a little bit of shadowing here. Either there was no embryo or some embryos are without a heartbeat here, but once the yolk sac becomes calcified, pretty much it's a non-viable pregnancy. Here's an example of a calcified yolk sac again. A little bit about the amnion, the empty amnion sign. The amnion is to be distinguished from the yolk sac. Yolk sac is a relatively small structure. Amnion increases with size over the first trimester of pregnancy and then fuses with the chorion, usually around 14 to 16 weeks. Amnion is not normally seen until 7 weeks or so. If it's visible when the embryo is less than 7 meters, it's a poor prognosis, and it's helpful when you see a small embryo and don't see a heartbeat. And Dr. Philly nicely outlined this in 2009 in an article saying that if the amnion is seen and there's no embryonic heartbeat, there's a 0% chance of survival. There have also been reports of a thickened or bright amnion being a poor prognosis. I haven't really seen that finding. And also a guarded prognosis with a large amniotic cavity. Again, I don't know what really they're relating that to comparison. Here's the normal amnion. You get a little thickening here as the ultrasound beam is coming in perpendicular to it. Here's the yolk sac, here's the embryo here. Everything's all hunky-dory. Here's the expanded amnion sign that we see. It's a crown rump length right here. It's 3 millimeters. Did not see a heartbeat because there is this expanded amnion sign that Dr. Philly reported. We suggested a very poor prognosis, and it turned out to be a non-viable pregnancy. You can see here's the black and gray or grayscale ultrasound and the color Doppler showing absent embryonic heart rate. Unfortunately, I don't think these clips are going to play here. I just had a clip showing the same thing, the expanded amnion sign. So I find it to be a fairly helpful sign in first trimester suspicious failed abortion or missed abortion cases. Finally, the chorionic bump sign was described by myself and Dr. Misty Porter, among others, about 7 years ago now. Small series of about 15 cases, prevalence of about 0.7%. And we compared the chorionic bump patients to the general normal healthy control patients and the infertility patients as well. And we found certainly a worse outcome compared to the general control patients. There are only 7 live births in the bump patients versus 13 live births in the control patients. There was no significant difference, but a slight difference with the infertility control patients. Again, 7 live births in the bump patients versus 11 in the infertility control group. We found that the size was not correlated with the outcome. We felt that it probably represents a small intrauterine hematoma that instead of sort of outlining the gestational sac or the early placenta, bulges into the gestational sac. Not quite sure why it does that. We concluded it was a guarded prognosis with less than a 50% live birth rate. But if you look at our data a little bit more carefully, if they did have a positive embryonic heartbeat, that was a good prognostic sign. 4 out of those 5 cases went on for a live birth. So we're trying to get the data together from a multi-institutional study here, but it's kind of tough going. Anyway, here's evidence of a chorionic bump. This is not the embryo. This is a chorionic bump. I don't think there was an embryo in this case here. Here's a larger bump. Here's the embryo next to it. If you put color on, you often see not flow in it, but you can sometimes see little echoes swirling around in it. So to summarize, Moeller disease presents as a spectrum. It's very interesting epidemiologically and genetically, somewhat interesting ultrasonographically, but ultrasound is not very sensitive or specific in determining whether it's a partial mole or hydropic degeneration. But anytime I see a very cystic-y placenta with an abnormal gestational sac and it looks like it could be a partial mole, I mentioned it in the report. A lot of times we'll do a DNC in those cases, give us some feedback. Expanded amnion sign, in pretty good hands, has 100% positive predictive value for failed pregnancy when the embryo has no heartbeat and less than 5 millimeters crown rump length. And finally, the chorionic bump probably has a pretty good prognosis if there is embryonic heart activity. And I think that's it.